Welcome back to the deep dive. Today we are wading into some pretty deep and high-stakes waters. We're talking about trauma anesthesia.
It's relentless, isn't it? Trauma is still a huge cause of death and disability for all ages.
Yeah.
But the goal for us, for clinicians, isn't to just know a list of injuries.
No.
The mission today is, well, it's tactical. We're here to turn that mountain of knowledge into a very rigid, very clear decision algorithm. It's what you do when you're standing over that patient and the clock is ticking.
Exactly. This deep dive is for the MD level clinician. So whether you've got a theory exam coming up, a Viva that you're, sweating about, or you're about to walk into the resus bay, this is for you. We're moving beyond the textbook.
And that gets us to the absolute core philosophy. The one thing you have to remember above all else, especially when time and resources are short, trauma management is about doing the right thing first, not doing everything.
Right. It's about triage, but for your own actions.
Precisely. It's about prioritizing life, prioritizing physiology, over getting a perfect diagnosis in that so-called golden hour.
So let's start there. Let's define the battlefield. This isn't your standard elective surgery, is it? What's the working definition of trauma anesthesia?
Not at all. Trauma anesthesia is really, it's anesthetic principles applied to a patient who is acutely injured and fundamentally unstable. That's the defining word, unstable.
And what does that instability look like?
It means they're often actively bleeding, they're in profound shock or about to be, and their intravascular status, how much fluid is actually in the tank, is a huge evolving question mark.
So you're playing this high-stakes game with, like, half the rules missing. What are the immediate assumptions, the things you have to accept as true from the second that patient comes through the door?
There are 4 clinical realities you just have to bake into your thinking. First, every single one of them is full stomach, period. Gastric emptying just stops with severe injury.
So aspiration risk is through the roof.
100%.
Right.
Second, until it is definitively cleared, you must treat every blunt trauma patient as if they have an unstable cervical spine. No exceptions.
Oh.
Third, their history. It's a black box. You don't know about the cardiac disease, there's no anticoagulants, nothing. And fourth, you have to be ready for immediate life-saving surgery. That means you need a plan for a safe but incredibly fast induction.
You remember in the golden hour, it's a term everyone knows, but let's break down why that specific window of time is so critical.
It's so pivotal because what we do in that hour directly fights the major peaks of trauma mortality. The first peak is immediate death on scene, often unpreventable.
Right.
But the second peak, that's our peak. It happens minutes to hours later, and it's from things we can fix. Airway obstruction, breathing failure, and most commonly, uncontrolled hemorrhage.
And our actions in that first hour also affect the third peak, don't they? The one that happens much later.
That's exactly right. The third peak happens days, even weeks later. It's death from sepsis and multi-organ failure, or MOF. And the root cause of that delayed MOF is often the profound shock and poor tissue perfusion that happened way back in that first hour. So what you do at the start dictates the entire course.
So if we're building that mental checklist, the hierarchy of needs for the anesthesiologist who's under immense pressure, what are the big overarching goals in order of threat?
It's pure survival logic. Number 1, oxygenation and ventilation. Without oxygen getting to the tissues, it's game over in minutes.
Okay, A and B.
Exactly. Second is perfusion and hemorrhage control. That means stopping the bleed, but also intelligently restoring circulation with something called damage control resuscitation. We need to get that oxygenated blood moving.
And then?
Third, and this is a distinct goal, is neuroprotection, especially with traumatic brain injury, TBI, or spinal cord injury. We have to actively protect the central nervous system. And fourth, running in the background through all of this, is lethal triad prevention.
Ah, the triad.
Yes, keeping them warm, keeping their pH normal, and making sure their blood can actually clot. Those 4 goals drive every single thing we do next.
Okay, so that brings us to the actual doing. The ATLS primary survey, this is the playbook, right? The algorithm to bring structure to the chaos.
It is the non-negotiable algorithm. This is the highest yield part of this entire discussion for any clinician or examiner. It forces you to act in the right sequence.
And the rule throughout is always protect the C-spine.
Always.
So let's start with airway maintenance with cervical spine control. How do you make that first rapid assessment?
The quickest way is just to ask them a question. If the patient is speaking to you in clear sentences, their airway is probably patent for now.
For now?
Exactly. It's not necessarily protected. But there are some absolute non-negotiable triggers where you don't wait, you just move to secure a definitive airway.
And what's on that list, the Intubate Now list?
Top of the list, the classic one, is severe TBI, a Glasgow Coma Scale or GCS of 8 or less. You intubate them to protect against aspiration and to control their ventilation, which helps manage pressure in the head. Any evidence of brain herniation, a spinal injury high up above C4, that's going to knock out their diaphragm. If they've lost their protective reflexes, like their gag reflex, or, and this is key, if you anticipate the airway is going to get worse.
Like in a fire with smoke inhalation.
Perfect example.
Yeah.
Or major facial trauma. You intubate early before the swelling makes it impossible.
And securing that airway has to happen while navigating the C-spine. You said we must use manual inline stabilization, MILS. What does that actually involve?
It's mandatory. It's non-negotiable. It requires a dedicated assistant, usually at the head of the bed. Their only job is to hold the patient's head and neck in a neutral, stable position. They typically grasp the mastoid process.
And you can take the collar off.
You can and should remove the front part of the hard collar. You need that space to open the mouth and get the laryngoscope in. But the key instruction for the assistant is this. You are stabilizing, not pulling. No excessive traction. That could actually make a fracture worse.
That raises a really practical question. You're doing RSI with MILS, you can't extend the neck, and you get a poor view. Why not just pop in an LMA, a laryngeal mask airway, to get some ventilation going?
That is a critical question. And the answer is all about protection. Remember, the definition of a definitive airway in trauma is a cuffed tube in the trachea.
Because of the full stomach.
Because of the full stomach. An LMA can be a lifesaver in a true can't intubate, can't ventilate situation, but it does not protect against aspiration. So if your first attempt at laryngoscopy fails and you can't ventilate safely, you have to move straight to the surgical airway. Cricothyroidotomy. Hesitation there is what leads to hypoxia.
Okay. Let's move to bi-breathing and ventilation. Airway is secure, or we're assessing, what are the 5 chest injuries that will kill the patient right now if we miss them?
You're looking at the rate, the pattern, how the chest rises, listening to breath sounds, and you are hunting for 5 things. Tension pneumothorax, open pneumothorax, flail chest, massive hemothorax, and cardiac tamponade.
Let's focus on tension pneumothorax. You say it's a clinical diagnosis. What does that mean we should see?
It means you do not wait for a chest x-ray. The signs are respiratory distress. One side of the chest has reduced or no breath sounds. It's hyperresonant when you tap it, and the patient is hypotensive and tachycardic. Tracheal deviation is a very, very late sign.
So what's the immediate move?
Immediate decompression. You take a large 14-gauge cannula and you put it in the second intercostal space, midclavicular line. That vents the pressure, turning the tension pneumo into a simple one.
And that's not the final fix, is it?
No, that's a temporizing measure. The definitive treatment is a large chest drain, a 36 French gauge tube, put into the 5th intercostal space just anterior to the mid-axillary line. The one-liner for the exam is that no trauma patient should ever die without a potential tension pneumothorax being relieved.
You mentioned a really important trap. The patient is intubated, you start bagging them or put them on the ventilator, and they suddenly collapse. Why does that happen?
2 big reasons, and they're both about pressure. First, positive pressure ventilation. The PPV, it reduces the blood flow back to the heart. It drops their preload. If they're already profoundly hypovolemic, that can be the final straw.
And the second reason?
The second is more insidious. A small, simple pneumothorax that was stable can be converted into a life-threatening tension pneumothorax by the pressure from the ventilator. If that happens, you have to disconnect them from the ventilator immediately and decompress the chest.
Okay, let's go to sea circulation and hemorrhage control. Now we're shifting from delivering oxygen to delivering blood. Can you quickly walk us through the ATLS shock classification?
Of course. It's 4 classes, and it helps you gauge how bad the bleeding is. The key dividing line is between compensated and decompensated shock.
So classes 1 and 2?
Those are compensated. They've lost up to about 30% of their blood volume, maybe 1,500 mils. Their blood pressure is still holding up because their body is compensating with massive vasoconstriction, but their heart rate will be climbing.
And then the cliff classes 3 and 4?
That's the decompensated zone. Now they've lost 30–40% or more of their blood. This is where the blood pressure finally drops. They become confused, lethargic. Class 4, with over 40% blood loss, carries a huge mortality rate. This is massive transfusion territory.
Before we even think about replacing blood, we have to stop the loss. If there's catastrophic external bleeding, the protocol changes, right?
Absolutely. The second you see a major arterial bleed, the whole algorithm flips. It becomes CAB. You control that catastrophic hemorrhage first. direct pressure or tourniquet, whatever it takes.
Yeah.
That always comes before traditional airway and breathing.
This leads us right into a core tenet of modern trauma care: permissive hypotension. What is it, and why are we deliberately keeping the blood pressure low?
Permissive hypotension is a key part of damage control resuscitation. We are actively targeting a lower systolic blood pressure, usually around 80 to 90 millimeters of mercury.
That seems so counterintuitive.
It is, but the physiology is sound. The goal is to avoid popping the clot. If there's a fragile clot forming at the site of the bleed, and you crank the pressure up too high with aggressive fluid resuscitation,
You just blow it off?
you blow it off and the bleeding starts all over again. It also helps limit how much crystalloid fluid we use, which we now know is harmful. It's a bridge to get them to the operating room where the surgeon can get definitive control.
But there has to be a situation where this is a terrible idea, the absolute contraindication.
Yes, and this is the one every examiner is waiting for you to say. Permissive hypotension is absolutely contraindicated if you have a patient with a traumatic brain injury or a spinal cord injury.
Why?
Because in those patients, perfusion to the central nervous system is everything. We need to maintain a normal blood pressure to ensure adequate cerebral perfusion pressure. A low systemic blood pressure is one of the worst secondary insults you can give to an injured brain.
Got it. Moving quickly through disability.
This is your rapid neuroassessment. The GCS is your main tool here, and as we said, a GCS of 8 or less, you intubate. But the other key goal here during that intubation is neuroprotection. You have to use your drugs to blunt the sympathetic surge from putting the tube in, because that surge can cause a dangerous spike in intracranial pressure.
And finally, e-exposure and environment. Why is getting the patient warm so important?
Because they get cold so fast. You have to expose them to do the primary survey, and then we often pour in large volumes of room temperature IV fluids. Hypothermia isn't just a comfort issue, it's a key part of the lethal triad. We have to start rewarming them immediately. Warm fluids through a rapid infuser, warm blankets, turn up the heat in the room. And if a patient is in cardiac arrest, the rule is you aren't dead until you're warm and dead. You have to keep resuscitating until you've corrected the hypothermia.
Okay, so once those immediate life threats are managed, we shift gears to the secondary survey. What's the objective here?
If the primary survey is finding what kills you now, the secondary survey is a much more detailed head-to-toe exam to find the injuries that might kill you later. It's all about reducing the rate of missed injuries.
And this is where more advanced imaging comes in. Tell us about the FAST scan.
The fast scan-focused assessment with sonography and trauma is a game changer. It's a quick ultrasound done at the bedside. You're looking for free fluid, basically blood, in the abdomen or around the heart.
And a positive scan means what?
A positive fast scan in a patient who is hypotensive is often a trigger to activate the massive transfusion protocol and a ticket straight to the operating room. It tells you there's internal bleeding that needs surgical control.
And what about the big gun, the CT scanner?
A full-body CT scan is fantastic for mapping out all the injuries, but it comes with a huge caveat. The patient has to be stable enough, and their airway has to be completely secure. The one rule you cannot break is that a trip to the CT scanner must never delay life-saving surgery for uncontrolled bleeding.
Let's talk about monitoring. We need more than just a pulse ox and a BP cuff here, I assume.
Absolutely. The standard monitors are just the start. Given the instability, you want to get an invasive arterial line in as soon as possible. It gives you continuous beat-to-beat blood pressure, which is critical when you're targeting permissive hypotension. You also need a core temperature probe and a catheter to measure urine output.
And what about the deeper cellular level monitoring?
Right. We need to know if our resuscitation is actually working at the tissue level. That's where we look at serial lactate levels and the base deficit. A base deficit worse than -10 is another one of those lab triggers for activating the MTP. It tells you the patient is in severe shock.
This brings us to the OR and the concept of damage control surgery, or DCS. What exactly is this approach?
DCS is a deliberately abbreviated operation. The surgeon goes in with very limited goals. Stop the major hemorrhage, usually by packing or ligating vessels, and control any major contamination, like from a bowel injury. They are not doing the final definitive repair.
So they do the bare minimum and then get out.
Exactly. They get in and out fast, maybe in 60 to 90 minutes. Then the patient goes to the ICU. This gives the anesthesia team a window to aggressively resuscitate them, to fix the physiology, the acidosis, the hypothermia, the coagulopathy, before the body is subjected to the stress, the massive long operation.
So during that short, sharp DCS procedure, what are our priorities as anesthesiologists?
Survival. Pure and simple. We're maintaining a very, very light plane of anesthesia. We're minimizing any drugs that might blunt their vital sympathetic drive. We're essentially just trying to keep them alive while the surgeon stops the bleeding.
And the definitive surgery, like fixing a complex fracture, when does that happen?
That timing is crucial. You have to wait. That big orthopedic surgery has to be delayed until the patient is physiologically stable, often 24 to 48 hours later. You have to get them warm, non-acidotic, and clotting properly first. Pushing for early definitive surgery in an unstable patient is a recipe for multi-organ failure.
Let's circle back to the airway, which you said is an exam favorite. What are the anatomical red flags that just scream difficult airway in the trauma bay?
Any significant maxillofacial trauma, a broken mandible, major facial or neck burns, all of these suggest the anatomy is going to be distorted. And remember, you can't extend the neck. So if you look at that patient and think oral intubation might fail, you need to be thinking about a surgical airway from the very beginning.
Let's talk about cricoid pressure during RSI. It's standard, but it's also controversial.
Yeah.
Why do we stick with it?
We stick with it because in this specific high-risk setting, the potential benefit of preventing aspiration is still considered worthwhile. The risk is 100%, so we use every tool we have.
But there's a modern caveat,
A
right?
huge one. The modern understanding and the key to answering this well is that if the cricoid pressure is making it difficult to see the vocal cords or pass the tube, it must be released immediately. Securing the airway is the #1 priority, and cricoid pressure should never get in the way of that.
And just to be crystal clear, why is nasotracheal intubation absolutely forbidden in head trauma?
Because of the risk of passing the tube directly into the brain. If there's a basilar skull fracture, which you often can't rule out, the tube can go through the fractured cribriform plate and into the cranium. It's an absolute contraindication. It must be orotracheal.
So what's the algorithm if that RSI attempt fails? It's a can't intubate, can't ventilate scenario.
You have to move fast.
Yeah.
If you fail to intubate and you can't keep their oxygen sets up with a mask or even a supraglottic device, you don't have time for more attempts. You have to declare a failed airway and move immediately to a surgical airway, an emergency cricothyroidotomy. Speed is everything.
Okay, let's talk drugs. The choice of induction agent is critical. You said that the loss of sympathetic tone is devastating in a shocked patient. Can you explain that a bit more?
Think of it this way. The shocked patient is only alive because of a massive surge of their own adrenaline. It's clamping down all their peripheral blood vessels to shunt what little blood they have to the brain and heart. Drugs like Propofol, benzodiazepines, even high-dose opioids. They're vasoplegic.
Yeah.
They switch off that sympathetic drive. The vessels all relax and the blood pressure just vanishes. It's like you've chemically bled them out.
So the drug choices are all about preserving that tone. Let's start with Etomidate.
Etomidate is often the go-to because it gives you rapid unconsciousness, but is known for being hemodynamically stable. It generally preserves that sympathetic tone. But, and this is a big but, the simple act of making them unconscious and starting positive pressure ventilation can still cause a significant drop in blood pressure. You can't let your guard down.
And what about ketamine?
Ketamine is also an excellent choice, often because it actually stimulates the sympathetic nervous system. It can increase heart rate and blood pressure. However, it's not a magic bullet. If the patient is in the end stages of shock, their own catecholamine stores might be totally depleted.
So ketamine has nothing left to stimulate.
Exactly. And in that rare case, its direct myocardial depressant effects can become unmasked, and they can still collapse.
So how should we dose ketamine in that critically ill patient?
Very, very carefully. Instead of giving a big bolus, you titrate it. Give small increments, maybe 10 or 20 milligrams at a time, until they lose consciousness. That gives you much more control and minimizes the risk of a sudden crash.
And propofol for induction.
If you absolutely have to use it, the doses have to be tiny. We're talking a quarter or even less of a normal induction dose, maybe 0.25 to 0.5 milligrams per kilogram. It's incredibly potent in these patients.
What if you have that patient who is crashing, they're conscious, but so unstable you're afraid any induction agent will kill them?
That's the nightmare scenario. In that situation, you might prioritize amnesia over deep anesthesia. The sources suggest considering an agent like scopolamine. It provides amnesia for the event without hammering their hemodynamics. They might still be aware on some level, but they won't form memories of it.
And for muscle relaxants.
Succinylcholine is fast, but you have to worry about hyperkalemia in crush injuries or burns after the first 24 hours. High-dose rocuronium, around 1.2 milligrams per kilogram, gives you a similarly rapid onset and is often a safer choice.
Let's shift to fluid resuscitation. This is all about damage control resuscitation, DCR. You said it's a philosophy. What are its pillars?
It's a three-pronged strategy. 1, get to surgical source control as fast as possible. 2, use the principle of permissive hypotension as a bridge to that surgery. And 3, aggressively restrict crystalloid fluids and instead give early, balanced blood products.
We used to pour liters and liters of saline into these patients. Why is that now considered so harmful?
We've learned that large volumes of crystalloid are actively toxic to a bleeding patient. They cause 3 huge problems. First, hemodilution. You're just watering down the clotting factors they have left. Second, hypothermia, if the fluids aren't warmed. And third, acidosis, especially with normal saline. The data is pretty scary. Giving more than 4 liters of crystalloid is strongly associated with developing a severe coagulopathy. You're literally making it impossible for them to clot.
So that's why we activate the massive transfusion protocol, the MTP. What are the key triggers for that?
MTP is for when you anticipate massive bleeding. The clinical triggers are things like a systolic blood pressure under 70 or a positive fast scan. But the lab triggers are just as important. A base excess worse than -10 or a core temp below 34 degrees Celsius. Those should also trigger an MTP activation, even if the blood pressure is holding on.
And the famous ratio, what is the crisp, exam-ready answer for the MTP ratio strategy?
The accepted strategy is a balanced ratio of packed red blood cells to fresh frozen plasma to platelets of 1 to 1 to 1. The goal is to replace what they're losing in a way that mimics whole blood, providing clotting factors and platelets along with the red cells.
And with FFP, how do we know we're giving enough to actually make a difference?
You have to give a therapeutic dose. The goal is to get their coagulation factor concentration up to at least 30% of normal. That requires a loading dose of about 10 to 15 mils per kilogram of FFP. It's a significant volume.
What about drugs to help with clotting? Where does tranexamic acid or TXA fit in?
TXA is an antifibrinolytic. It helps stabilize clots that have already formed by preventing them from being broken down too quickly. Based on the big CRASH-2 trial, it should be given early, ideally within 3 hours of the injury, to any trauma patient with significant bleeding.
Okay, let's focus now on that physiological disaster you mentioned earlier, the lethal triad. How does this vicious cycle of hypothermia, acidosis, and coagulopathy actually work?
It's a death spiral. Hypothermia directly slows down the enzymes in the clotting cascade. The platelets don't work well when they're cold. Acidosis does the same thing. It poisons the enzymatic reactions of coagulation.
So they feed each other.
Exactly. The coagulopathy leads to more bleeding, which worsens the shock and makes the acidosis and hypothermia worse. And that, in turn, makes the coagulopathy even more severe. It just cycles downwards.
To really show a deep understanding of this, you said we need to distinguish between the 2 types of trauma-induced coagulopathy, or T-type.
Yes, this is a key distinction. First, there's acute traumatic coagulopathy, or ATC. This is the coagulopathy caused by the injury itself. The massive shock and tissue damage trigger pathways that actively break down clots.
And the second type?
The second is the one we cause. It's called iatrogenic or resuscitation-associated coagulopathy, ITC or RAC. This is from pouring in too much crystalloid, letting the patient get cold, and not correcting their acidosis. We have to fight both at the same time.
So how do we manage the triad? And what's the one component that often gets forgotten?
You manage it by attacking all 3 parts at once. Aggressively warm the patient to keep their core temp above 35 degrees. Manage the acidosis by stopping the bleed and giving blood products instead of crystalloid. But the forgotten hero is ionized calcium. Calcium is a vital cofactor for almost every step of the clotting cascade. And the citrate in stored blood products chelates, or binds up the patient's calcium, causing severe hypocalcemia. You have to monitor it and replace it aggressively to keep the level above 1.0 millimole per liter. That's a huge Viva point.
Okay, let's pivot to some special scenarios that change the rules. First, head injury, TBI. The goal is maintaining cerebral perfusion. How do we manage ventilation?
The goal is normocarbia. You want to keep their PaTha2 in the normal range. If you hyperventilate them and blow off too much CO2, it causes cerebral vasoconstriction, which can lead to ischemia. If you let the CO2 rise, you get vasodilation and increased intracranial pressure. It's a fine balance.
Is there ever a role for deliberately hyperventilating them?
Only as a temporary last-ditch maneuver if they're actively showing signs of brain herniation. In that specific crisis, you can use mild hyperventilation to a PaTha2 about 35 to temporarily reduce ICP and buy time. But it's not a routine strategy.
What about spinal cord injury? They often present in neurogenic shock. What are the challenges there?
The airway is critical. An injury above C4 means their diaphragm won't work, so they need immediate intubation. And their circulation is tricky. They've had a chemical sympathectomy below the level of the injury, so they vasodilate and their blood pressure is low, but often their heart rate is normal or even slow.
So how do you treat that hypotension? It's not from blood loss.
First, you still have to make sure they haven't also lost blood. But once you've given a cautious fluid bolus, if the hypotension persists, the problem is the loss of vascular tone. So you need to treat it with vasopressors like norepinephrine to restore that squeeze and maintain perfusion.
And the pregnant trauma patient, obviously we prioritize the mother, but is there a unique challenge there?
The big challenge comes if the mother has a cardiac arrest and you need to institute targeted temperature management, or TTM, cooling her down to 32 to 34 degrees. While you follow the standard protocol for the mother, you must also maintain continuous fetal monitoring throughout the entire cooling and rewarming process. The fetus is incredibly vulnerable.
Let's talk about the next phase. The patient has survived the OR and now we're transferring to the ICU. How do we know if our resuscitation is actually complete? What's the checklist?
You need to hit objective goals, the bleeding has to be stopped, and you should see evidence of restored organ perfusion. We're looking for a systolic blood pressure above 100, a heart rate under 100, a normal pH and lactate, and a normal clotting profile. Until you hit those targets, resuscitation is still ongoing.
The decision to extubate is a huge one. What's the safety checklist you have to run through before pulling that tube?
It's twofold. First, systemic stability. They have to be fully resuscitated, warm, with no signs of sepsis, and a low chance of needing to go back to the OR. Second, respiratory mechanics. They need to have good tidal volume, a good respiratory rate, and be on less than 50% oxygen. The rule is simple. If you have any doubt at all about their stability or their ability to protect their airway, you leave the tube in and transfer them to the ICU intubated. A failed extubation and reintubation can be a catastrophic event.
And what about pain control in these complex patients?
If you can do it safely, regional techniques are far superior. An epidural or a nerve block can provide amazing pain relief, and that helps their pulmonary function tremendously. But you have to weigh that against any ongoing coagulopathy or the practical difficulty of positioning a polytrauma patient.
This all brings up some unique medical, legal, and ethical questions. How does consent work when the patient is unconscious and dying?
We operate under the principle of implied consent. The law assumes that a reasonable person would consent to life-saving treatment, so we act based on the greatest threat to life principle. And this is exactly why documentation is so critical. Every single decision, your drug choice, your use of permissive hypotension, the rationale for rushing to the OR, it all has to be documented clearly, explaining your thinking based on the patient's physiology at that exact moment.
Okay, we've covered the whole algorithm. Let's really synthesize this for exam purposes. Let's do some high-scoring comparisons. First up, trauma hypotension versus elective deliberate hypotension.
It's a world of difference. In trauma, the patient is vasoconstricted, the anesthesia is light, and their physiology is a mystery. In elective deliberate hypotension, the patient is vasodilated by deep anesthesia, and their physiology is completely optimized and controlled. They are polar opposites.
Next comparison, ketamine and etomidate versus propofol for induction and shock.
Ketamine and etomidate are chosen because they preserve or even stimulate the patient's own sympathetic tone, which is keeping them alive. Propofol does the exact opposite. It guarantees sympathetic attenuation and is therefore highly likely to cause cardiovascular collapse in a shock state.
And the final big one, crystalloid versus blood-based resuscitation.
Crystalloids cause an iatrogenic coagulopathy through dilution. They make the patient cold and acidotic. Blood-based resuscitation, or DCR, with a 1.1.1 ratio, minimizes dilution and actively treats the underlying coagulopathy by replacing the factors and platelets they're losing. It's a paradigm shift from volume replacement to factor replacement.
Let's get into a rapid-fire exam focus. What are the common long-form theory questions you should be ready for?
Be ready to write a structured essay on massive blood transfusion and its complications, a detailed breakdown of damage control resuscitation, and the overall role of the anesthetist in multiple trauma, where you should use the ABCDE framework as your answer structure.
And for short notes, or Viva?
The lethal triad. Permissive hypotension, including its targets and contraindications, the role and timing of tranexamic acid, and the use of the EFAST scan.
Now for the one-liners, the crisp answers that show you really get it.
Number 1. Trauma coagulopathy is managed by maintaining normothermia, a normal pH, and an ionized calcium level above 1.0 millimole per liter. Number 2. The target for permissive hypotension is a systolic of 80 to 90, unless there's a TBI or spinal cord injury. And number 3. The definitive airway in trauma is always a cuff tube in the trachea.
And finally, what are the common traps an examiner might set, or the dangerous practices to avoid?
Never, ever suggest nasal intubation if there's any chance of a head injury. Never advocate for just pouring in crystalloids to treat hemorrhagic shock. And in any discussion about the airway, you must always state that mills and full stomach precautions are mandatory.
This has been an incredibly dense but vital run-through. Let's end with that mental flow chart, the sequence you execute under fire.
It starts with CAB if there's catastrophic external bleeding. Then you secure the definitive airway with RSI and mills. You immediately treat life threats like attention pneumothorax. Then you implement permissive hypotension, unless there's a head injury, and you activate DCR and the MTP with a 1.1.1 ratio and TXA. That gets them to DCS to stop the bleeding while you are constantly fighting the lethal triad. And finally, you check the comprehensive extubation criteria before you even think about leaving the OR.
It really underscores how the anesthesiologist's role is to keep the patient alive at a cellular level.
That's it, exactly. Our job in that golden hour is to prevent the delayed deaths from multi-organ failure. It's not just about surviving the surgery, it's about surviving the ICU, and that requires us to fix their physiology.
Which brings us to our final provocative thought for you to take away. We've talked about two types of coagulopathy. The one the injury causes, ATC, and the one we can cause with our resuscitation, RAC. So here's the question. If you could only look at one single marker on the patient's immediate arrival, which one would better predict their risk of developing that iatrogenic resuscitation-associated coagulopathy? The total volume of crystalloid they received in the field, or their initial lactate level?
Think about what causes the dilution versus what reflects the shock state. Your answer to that question should fundamentally guide your initial fluid strategy from the moment they hit the door.
An incredible amount to think about. Thank you for joining us for this crucial deep dive. Go be well informed and stay safe.
Execute the algorithm.